What is a pneumothorax? How does it lead to obstructive shock? And what's the difference between a simple pneumo and a tension pneumo? Well, let's talk about it. A normal lung adheres to the chest wall with nothing more than negative pressure. The same way a suction cup can stick to a piece of glass. And if you poke even the smallest little hole in that suction cup, the suction cup loses that negative pressure and falls. Well, inside the chest cavity, the lung does the same thing. It's no longer stuck to the side of the chest. Now, this is a pneumothorax, but there's two different kinds. There's a simple pneumothorax and there's a tension pneumothorax. Now, in a simple pneumothorax, air is drawn into the chest, but it doesn't really go into this lung because that lung isn't expanding to create the negative pressure to draw in. So most of the air will go into the unaffected lung. Now, patient needs medical attention, they may need surgery, but this isn't an immediate life threat. It's not going to cause any significant changes in the blood pressure. Patient might report a little bit of chest pain, a little bit of difficulty breathing, but you're going to have a stable patient. Now, in tension pneumo, what happens is air gets into the chest either by breathing where it's closed, or you can have an exterior wound and air is getting in from the outside, but air is getting trapped in this space. And picture a balloon in your chest, and every breath you take, that balloon gets bigger and bigger. Well, that's what's happening with this space. Now, what's not in this picture is the heart. Let me change the color so we can actually see it. But we have the heart sitting right here in the middle, and we have some supply lines, or vena cava, coming off of it. And the superior vena cava, this top one, actually branches off and becomes the jugular veins, and that'll be important later on. Now, as this space fills with air, it's going to push this way. What's that going to cause? Well, big problem is it decreases preload, or the amount of blood that can get back to the heart. And it does that two ways. One, it's pinching off the supply line to the heart. The other way it does it is it smashes the heart, so the heart can't hold as much blood before it contracts. It also decreases stroke volume because that preload is decreasing, and because the heart can't fully expand, it can't contract as hard. Remember that Starling's law. Now, just as a quick recap, preload is the amount of blood that goes into the heart before the contraction. Stroke volume is the amount of blood that the heart ejects with each contraction. So, what are some of my findings? Well, as it's pushing this way, and this one's a late one, but it's very common and National Registry likes it, as that cavity fills up, it starts to push everything. We talked about that. This trachea is included. Now, that's a super late finding as far as a physical finding. However, you can see it much earlier on the chest x-ray. So if you're transporting a patient from facility to facility and you have access to the chest x-ray, you're going to see it on there long before you'll see the patient present with it. The other thing is the vena cava is being smashed, and that back pressure from the vena cava is going up into the jugular veins, and this is going to lead to JVD, or jugular vein distension. Now, because the heart's being smashed and we have the decrease in stroke volume and preload, we have a decrease in blood pressure, and this is where the obstructive shock comes in. That's how tension pneumothorax can lead to hypotension. And a lot of students will associate the word tension pneumo with a hypotension, so they can remember that the difference between a simple pneumothorax and a tension pneumothorax is the hypotension and JVD. Now, the other assessment finding that's pretty obvious is that the patient's going to have absent lung sounds on the affected area. So what do we do with this patient? Well, we're going to put them on high flow oxygen because we still have one good lung, right? And we want to be able to get as much oxygen on board as possible. And we know that this patient's going to need a needle chest decompression. If you have an open chest wound, and that's the source of your tension pneumo, we're going to put that three-sided flap so air can get out, but air can't get back in. One thing that we need to consider that's not mentioned enough in the textbooks is a little bit of hesitation on any kind of positive pressure ventilation. CPAP, BiPAP, BVM are going to make a tension pneumo much worse, much quicker. And if you have a patient with a simple pneumothorax, that positive pressure is going to turn it into a tension pneumo. And that's because air is normally being drawn in with negative pressure. And since the affected lung isn't fully expanding, it's not really drawing any significant air. But the good lung is. So the majority and the significant volume of air ends up going into the good lung. But if we put the patient on positive pressure ventilation, we're no longer drawing the air into the lungs, but we're pushing the air into the lungs. Half of that air is going to end up inside that chest cavity. So anytime we give a pneumothorax positive pressure ventilation, we're creating a tension pneumothorax. Now, if this is a closed pneumothorax, that's even worse because there's no way other than needle decompression to decrease the pressure in the chest. So we really want to avoid, or at least not be trigger happy on the positive pressure ventilation or CPAP or BiPAP. And that's about everything you need to know. And now you know how a tension pneumothorax causes obstructive shock. Just remember differentiating a tension pneumothorax from a simple pneumothorax. Both have absent or decreased lung sounds, but only tension pneumothorax is going to come with JVD and hypotension. If you see those on National Registry, you're dealing with a tension pneumothorax patient. Now let's move on to the next one.